Good morning, good afternoon, or good evening, depending on where you are. It is my pleasure to welcome you to this webinar organized by the Educational Committee of the International Menopause Society. I will be the moderator. My name is Antonio Cano, and I am professor of obstetrics and gynecology at the University of Valencia in Spain. I have been the president of the European Menopause and Andropause Society, and currently I am co-chairman of the Council of Affiliated Menopause Societies at the IMS, and also a member of the Committee for Educational Activities of the International Menopause Society. The title, as you see in your screen of the webinar, is Hormones and Stroke, an update on treatment and risk. And for that, we have the privilege to have very reputed speakers. We have, firstly, Dr. Matthew Nudy, who will speak about hormonal effects on the risk of stroke. Dr. Nudy is an assistant professor of medicine and public health sciences at Pennsylvania State College of Medicine. He is a practicing preventive cardiologist, and his research focuses on prevention of cardiovascular disease in women, including the prevention of coronary heart disease and stroke. Then the second title is New Treatments in Stroke Prevention and Management. And for that, we will have Professor Dominique Cadilhac. This will be pre-recorded because she is actually in Australia, as I will now comment about the details of her biography. She has researched on the area of improving patient care and outcomes in stroke, an area in which she has published more than 350 papers. She is the co-director of Stroke and Aging Research at the School of Clinical Sciences in Monash University and data custodian in the Australian Stroke Clinical Registry in Florey Institute. As I said, this presentation has been pre-recorded, so once we arrive at the questions and answers, which will be at the end of both talks, we will be able to address questions mainly to Professor Nudy, as commented. So, as I said, we have an area, a topic, which is always in our practice, because as you know, cardiovascular disease is the main killer of women, not only in men. So this is something important because stroke is a main area in cardiovascular disease. So once completed this brief introduction, we will start with Professor Nudy. So Professor Nudy, the stage is yours. This webinar, as all the others in the series, has been supported by an unrestricted educational grant from the SINS Healthcare. As you see in your slides, in your screen, the SINS Healthcare had no role in the selection of topics or speakers and has not vetted or reviewed the content of the speakers' presentations. Having said so, please, Professor Nudy, you may start your presentation.
All right, Professor Cano, thank you for that introduction. As mentioned, my name is Matthew Nudy. I'm a cardiologist in the United States, and I am going to be giving a lecture on the hormonal effects on stroke risk. So I have no disclosures and no conflicts of interest. The presentation objectives for today are going to be the following. So we're going to describe the risk factors for stroke and also cardiovascular disease. And we're going to include risk factors that are specific to women that may increase the risk of stroke, which may be hormonally mediated. We're going to discuss the clinical trials that tested the effects of oral hormone therapy on stroke risk. We're going to look at the West trial, HERS, and the WHI. We're also going to understand something called the timing hypothesis as it relates to coronary heart disease. And we're going to review data that investigates the timing hypothesis and the risk of stroke. And we're also going to look at observational data investigating transdermal estrogen use and the risk of stroke. So we're briefly going to go into some background, and I'm not going to focus a lot on the background of stroke because Professor Cadilhac in her presentation will go into more detail. But stroke is the leading cause of prolonged adult disability. And we also know that women may face some disparities when it comes to stroke care. So women have less favorable functional outcomes following stroke compared to men. We also know that women, when they experience coronary heart disease, also have disparities as well. And women for coronary heart disease, and women typically have a worse prognosis following myocardial infarction compared to men. We know that stroke is a very common cause of death among women. And we know that the mean age of a first stroke occurs 4 years later for women compared to men, 75 years versus 71 years, and that may be hormonally mediated. During the 10 years after menopause, the risk of stroke nearly doubles in women. And it's suspected that these sex differences in stroke epidemiology may be hormonally mediated. Ovarian estrogens produced cyclically during the reproductive years may work to reduce the risk of stroke in women. Endogenous estrogen concentrations decline by a significant amount during menopause, and that may be a contributing factor to increased cardiovascular disease risk factors and ultimately an increased risk of stroke. We also know that estrogen has a very complex interplay on the body and has a very complex interplay on the neurologic system and may affect neurons, glia, the vascular endothelium in the brain, smooth muscle, lipids, protein, and inflammation. And all of this may have an effect on stroke risk. I wanted to take some time to define some stages of cardiovascular disease prevention. And this term cardiovascular disease is very much an umbrella term, and stroke falls under the umbrella of cardiovascular disease. So the first stage of prevention is called primary prevention. And this would be the prevention of a first heart attack or a first stroke. There's also secondary prevention as well, and this would be prevention of a second or recurrent stroke. There's also a newer term in the literature called primordial prevention. And this term refers to the prevention of cardiovascular disease risk factors. And this is especially important in younger individuals, as we're seeing younger and younger patients with obesity, high blood pressure, hyperlipidemia, and the metabolic syndrome, all which increase the risk of stroke later in life. So we have some traditional risk factors for cardiovascular disease. These include diabetes, hypertension or elevated blood pressure, obesity, tobacco use, high cholesterol, age, and family history of premature cardiovascular disease. Specific to stroke, we also know that an arrhythmia called atrial fibrillation also increases the risk of a certain type of stroke called a cardioembolic stroke. We also know that risk factors in women may affect the risk of cardiovascular disease different in men. For example, women with diabetes have a twofold increased risk of cardiovascular disease compared to men with diabetes. We also have risk enhancers for cardiovascular disease, and these have made their way into some of the guidelines in the United States and Europe. So we know that South Asian ancestry, chronic kidney disease, metabolic syndrome, also some adverse pregnancy outcomes like preeclampsia and preterm delivery increase the risk of cardiovascular disease. We also know that premature menopause with menopause onset before the age of 40 increases the risk of cardiovascular disease and stroke. Inflammatory conditions like rheumatoid arthritis, lupus, and psoriasis, which may be more prevalent in women, increase the risk of cardiovascular disease. Also HIV and some elevated biomarkers. There's also some thought that moderate to severe menopausal symptoms or vasomotor symptoms may increase the risk of cardiovascular disease. So looking at some of the data behind premature menopause and stroke, there was a study called the Framingham study, which was a prospective study. They investigated 2,783 women, and they specifically looked at the age of natural menopause. So if you look at this figure on the left side of the screen, the x-axis represents age between 60 and 100 years, and the y-axis represents the cumulative incidence of stroke. The dark line represents women who had natural menopause before the age of 42. The light dotted or the darker dotted line represents those who had natural menopause between 42 and 54 years. And the lighter dotted line represents those who had natural menopause greater than 55 years. And what we can see here is that the risk of stroke with natural menopause before the age of 42 is nearly double, with a hazard ratio of 2.03. There is another cohort of over 16,000 women from the Netherlands with a mean age of menopause of 46 years. And what they found is that when women had menopause before the age of 40, there was an increased risk of total stroke, and it was about a 48% relative increase. Most of the strokes in this study were ischemic. They also did a continuous analysis where a 2% lower total stroke risk was observed each year that menopause was delayed. As I mentioned before, there may be an association between moderate to severe menopausal symptoms and stroke. So this is a study that I did with some other investigators in more than 19,000 postmenopausal women enrolled in the Women's Health Initiative Calcium and Vitamin D trial. And we specifically looked at the number of moderate to severe menopausal symptoms. And we used a long list of symptoms, including hot flashes, night sweats, but also included other symptoms like sleep disturbances, feeling anxious, fidgety, also some somatic symptoms like pain. And we looked at a whole host of outcomes. And what was interesting is that when we looked at stroke, those women with more than 2 moderate to severe menopausal symptoms were at an increased risk of stroke later in life. I'm going to pivot now and talk about some of the clinical trials that have tested the effect of hormone therapy on stroke. The first trial that I wanted to talk about was the Women's Estrogen for Stroke trial, or the WEST trial. So this was a randomized, double-blind, placebo-controlled trial. They tested 1 milligram of estradiol 17 beta per day versus placebo. About 45% of the women had a prior hysterectomy, and women with a uterus underwent a yearly endometrial ultrasound or 12 days of medroxyprogesterone per year. This trial included 664 postmenopausal women with a mean age of 71 years. To be included in this trial, participants had to have a prior ischemic stroke or a transient ischemic attack within 90 days of enrollment. So this would be considered a secondary prevention trial for stroke. The mean follow-up was 2.8 years, and this study was published in 2001. The primary outcome of the trial was death or non-fatal stroke. And here are the results of the WEST trial. So for their primary outcome, death or non-fatal stroke, the relative risk was 1.1, and the hazard ratio was the 95% confidence interval was between 0.8 and 1.4. And you can see the figure on the right, where the dark line represents those randomized to estradiol, and the light line represents those randomized to placebo. The y-axis is percent of patients with a primary outcome event. They also looked at the individual components of the primary outcome, death and non-fatal stroke, and the relative risk was 1.2 and 1.0 respectively, with both confidence intervals crossing 1. They did a post hoc analysis looking at only the first 6 months of the trial, and they found a near double risk of stroke with estradiol within the first 6 months of the trial. And you can see that on the figure on the right. If you were to look at where about the 6-month mark would be, you could see that there's an increased risk of stroke and death with estradiol at the first 6 months. There were numerically higher fatal stroke with estrogen, but this did not meet statistical significance, and numerically worse neurologic and functional scores with non-fatal stroke among those randomized to estradiol, but again, this did not meet statistical significance. The next trial that I wanted to look at was the HERS trial. So this randomized 2,763 women with a mean age of 66.7 and followed these patients or participants for 4.1 years. All patients had documented coronary heart disease, and they randomized women to 0.625 milligrams of conjugated equine estrogen or 2.5 milligrams of medroxyprogesterone versus placebo. Important to note that the primary outcome of this trial did not include stroke. Stroke was a secondary outcome in this trial, but there was no difference in stroke and TIA between estrogen and progestin and placebo. And also when they looked at some individual components of stroke, like non-fatal stroke, fatal stroke, and transient ischemic attack, there was no increased risk. And also important to note that most of the strokes in this trial were ischemic strokes. The next trial that I wanted to look at was the Women's Health Initiative, which is one of the largest trials of hormone therapy on multiple health outcomes. They randomized over 27,000 women between the ages of 50 and 79 years. The average age of women in these trials were about 63 years. There were 2 parallel hormone therapy trials stratified by hysterectomy status. So among women with a prior hysterectomy, they randomized participants to 0.625 milligrams of conjugated equine estrogen versus placebo. And for those patients with an intact uterus, they randomized participants to 0.625 milligrams of conjugated equine estrogen and 2.5 milligrams of medroxyprogesterone compared to placebo. In both of these trials, about 80% of the strokes were ischemic strokes compared to hemorrhagic stroke. And here are the results for stroke. Just like the HERS trial, stroke was not the primary outcome of the WHI. Stroke was one of the secondary outcomes. On the left-hand side of the screen, you can see the CEE or conjugated equine estrogen alone trial. The blue line represents those randomized to CEE. The black line represents those randomized to placebo, and there was about a 39% relative increase in the risk of stroke for all trial participants randomized to CEE. On the right-hand side of the screen, we have the estrogen and progestin trial, with the lighter line representing those randomized to estrogen and progestin, and the darker line representing those randomized to placebo. And there's a 31% relative increase in the risk of stroke with estrogen and progestin. The excess risk corresponds to about 9 additional cases of stroke per 10,000 person years of hormone use. The increased risk primarily affected ischemic stroke, although the study had limited power to evaluate hemorrhagic stroke. And for women with a stroke, severity was assessed at the time of discharge with the Glasgow Outcome Scale, and that did not differ between those randomized to hormone therapy and those randomized to placebo. Here's a figure from a WHI publication in 2013, and I think this figure is really interesting. It looks at the absolute risk and risk difference for stroke during the intervention phase of the WHI clinical trial. The results are stratified by age, so those 50 to 59 at baseline, those 60 to 69 at baseline, and those 70 to 79 at baseline. And it's also stratified by the estrogen and progestin trial and also the estrogen alone trial. Those randomized to hormone therapy is represented by the black bar, and those randomized to placebo is represented by the light gray bar. And what you can see is that in the younger menopausal women, the risk difference for stroke is quite small. And in the estrogen and progestin trial, it's quite rare, a stroke, in the younger individuals. And in the estrogen alone clinical trial, among those 50 to 59, there's actually a slightly less risk difference in stroke, which is interesting. And I think this figure sets up nicely a discussion on something called the timing hypothesis. So the timing hypothesis states that the effects of estrogen is mediated by age or time since menopause, meaning that when younger menopausal women closer to the onset of menopause take estrogen, there may be benefit, but when older women further from the onset of menopause take estrogen, there may be harm. And this has actually been shown very nicely for coronary heart disease or coronary artery atherosclerosis. And Dr. Clarkson, who has since passed away from the Wake Forest University Primate Center, has shown this quite nicely in non-human primates. So when they induce surgical menopause in non-human primates and they delay estrogen, there's no difference in coronary artery plaque size. However, when they induce surgical menopause in non-human primates and immediately start estrogen, there's about a 70% reduction in plaque size later in life compared to control. So how about the timing hypothesis and stroke? So it works out quite nicely for coronary heart disease. Well, the effect of hormone therapy on stroke does not appear to be modified by age or years since menopause. And when analyzing data from the WHI, those within 10 years of menopause onset have a similar risk of stroke compared to women who are greater than 10 years for menopause onset. And women seem to be at an elevated risk of stroke regardless of age of initiation, even if it's quite rare in younger participants. There's an observational study investigating this called the Nurses' Health Study. So this was a prospective observational study, and they found an increased risk of stroke among women taking estrogen and also estrogen with progestin. The increased risk was observed for women initiating hormone therapy at younger ages and also near menopause onset compared to older ages and greater than 10 years from menopause onset. And there was a strong association between dose of estrogen and risk of stroke. Here's a meta-analysis that I did looking at all of the randomized clinical trials testing hormone therapy on the risk of stroke. We did analyze a composite outcome of stroke, TIA, and also systemic embolism. The forest plot on the left shows an increased risk with hormone therapy. We then did a subgroup analysis, and that's represented on the right-hand side of the screen, where we looked at the mean age of trial participants at baseline, and we did a subgroup analysis for those less than 60 years and those greater than 60 years, and both subgroups were at an elevated risk of stroke, TIA, and systemic embolism. We also did a meta-regression in this study where we looked at hormone therapy's effect on stroke based off mean age of trial participants. And as the mean age of trial participants increased, the risk of stroke appeared to increase as well. So as far as the government-approved indications for hormone therapy in the United States, those include moderate to severe vasomotor symptoms, prevention of osteoporosis, treatment of hypoestrogenism, treatment of moderate to severe vulvovaginal atrophy. There are also contraindications, and what's important here is that prior stroke is listed as a contraindication. Finally, I just wanted to talk about transdermal estrogen and the risk of stroke. It may be safer compared to oral estrogen, and it may have something to do with the first pass liver metabolism that oral estrogen undergoes. When transdermal estrogen is used, there's no increase in clotting factors and inflammatory markers, and this may reduce stroke risk. However, there's no randomized clinical trial testing the effect of transdermal estrogen on stroke. The data is mainly limited to observational data. Here's one observational study, a nested case control study of ischemic stroke among women in France. And essentially what they found, if you look on the panel to the right, is that when women used transdermal estrogen, there was no increase in total stroke. The panel on the left represents women who used oral estrogen, and at higher dosages of oral estrogen, there was an increased risk of stroke in this observational study. So here's my final slide, the key points. So there are certain risk factors for stroke that may be hormonally mediated, such as premature menopause. Also, moderate to severe vasomotor symptoms may contribute to stroke risk. Hormone therapy is not recommended for the prevention of stroke, either primary or secondary prevention. Hormone therapy is contraindicated in the United States among patients with a prior stroke. When younger menopausal women take hormone therapy, the absolute risk is small, but is present for stroke. Transdermal estrogen may be associated with a reduced risk of stroke compared to oral estrogen. However, this is really based on low quality evidence. And this is a point taken from the Menopause Society's hormone position statement that shared decision-making should be used when considering formulation, route of administration, and dose of hormone therapy, with adjustment tailored to symptom relief, patient preference, and adverse events. So thank you. Here's my email. You're more than welcome to send me an email. And it sounds like we'll be taking questions at the end of the presentation.
Many thanks, Professor Nudy. Yes, we will take questions and answers at the very end. Many thanks for this excellent talk. And I think we have plenty of questions for the Q&A session. Now, it's the time to present the video, yes, by Professor Cadilhac.
Thank you for inviting me to speak to you today about new treatments in stroke prevention and management. I'm Professor Cadilhac from Monash University, and I also have an appointment at the Florey Institute. This is my group. We cover a whole range of different areas of health services research, economic evaluation, epidemiology, health information management, and health promotion in the work, and we're currently based at the Victorian Heart Hospital, which is the only dedicated heart hospital in Australia. What I'm speaking to you about today is stroke. And you would have heard from the previous speaker about how hormones affect the risk of having a stroke. So I'm talking to you about what stroke is and what causes stroke, but then also what we can do to reduce death and disability from stroke. So the main two types of stroke are those caused by ischemia. So that's when there's a blockage in an artery of the brain. And a bleed is when a blood vessel ruptures or bursts, on the surface of the brain. And the main risk factors that we can modify include high blood pressure, hyperlipidemia, alcohol consumption. There are cardiac causes, including atrial fibrillation, which is a very important one in older women. Smoking, overweight, diet, and physical inactivity. Things we can't change are our age and our sex, or our race and ethnicity. And more we are finding that there are more evidence gathering around the influence of genetics as a potentially modifiable factor through gene-environment interaction. Throughout my presentation, I have included some QR codes, so these can take you to the references that I've used. So it is a leading cause of death and disability, and the Global Burden of Disease study has estimated that in 2019, we had over 12 million incident cases of stroke and over 101 million prevalent cases. That's people living with stroke in our community. However, some of the work that we've done with the Global Stroke Statistics publications, which I'm one of the lead authors on, indicates that there's a lot of variation in what we know about the impact of stroke in different countries, the incident rates, as well as information about death and disability. For example, this just shows you case fatality with women highlighted in the box symbol between the different countries. And you can see even like within and between countries, there is a very big difference in the case fatality amongst men and women. However, for example, if you look at Sweden or Croatia, Belarus, it seems to be that that's more equivalent. So we really need to understand in each of our settings and the regions in which we live, what is impacting the differences in stroke, not only incidence, but also case fatality, and why there are variations by sex. Why we are concerned about and why it is important to consider effective prevention and treatment is that the number of new strokes is increasing, as well as the deaths. So with a lot of new intervention that's come through recently with thrombolysis treatment and better care in hospitals, we certainly have curbed the death rate, but this is starting to go back up. And in terms of people surviving, many more people are now surviving their incident strokes, but many of them live with disability. In fact, 1 in 2 people who survive will have some form of disability where stroke has impacted their ability to speak, use their arm, walk, feel sensations, and think clearly. The other concerning trends that we are seeing is that more and more we're finding that the incidence of stroke is increasing in young people, in particular those who are aged 15 to 49. So what is impacting the stroke disease burden? There are demographic factors, so population growth and ageing. Age is one of the strongest risk factors for stroke. And there are also non-demographic factors related to our health sector, so healthcare access, as well as what treatment's available, and risk factors. And then there are non-health sector factors like economic development, education, and the social safety net. So as health services researchers and clinicians, we try to understand the things that we can influence to reduce any disparities in care, but also ensuring that care can be equally provided to the same quality, no matter whether you get treated in a hospital in a city or in a regional area. So there has been studies that have reported, or the main study called Interstroke, which is a case-controlled study conducted in 32 countries, that found that 10 of the risk factors explain 90% of the stroke risk. And there was important regional variation. So again, this talks to the fact that we need country-specific approaches to dealing with our own circumstances and population influences, as well as the health sector and non-health sector factors. Some work that has recently been done by my colleague Shauna Gall from the University of Tasmania has indicated that overall, men have a greater burden of cardiovascular disease than women over most of their life course. However, the differences in cardiovascular disease risk factors over the life course may explain these differences that we see between men and women. So it's really understanding that cardiovascular disease profiles of patients and at what time they impact, including at different ages. And in our national reporting within Australia, we've really only focused on single cardiovascular risk factors. So this team sought to understand trends between men and women over time, and they accessed national health data, survey data for this. And what they found that was the prevalence of high cardiovascular health scores in women in young, middle and older age groups over time varied. And you can see that there, and it was significant in terms of that age group that would be in that premenopausal, menopausal range in terms of the increase in prevalence of these high cardiovascular risk scores. Now, these risk scores are calculated based on the Modified American Heart Association Life Simple 7 metrics. So the findings from these authors overall was that women had better cardiovascular health across the life course compared to men from these data, However, for most age and sex groups, there has been no positive changes overall for cardiovascular health in the last 10 years, and that was being driven by a worsening body mass index and blood pressure levels amongst those responding to the surveys. There were positive changes in reductions in smoking levels and also diet in the younger age groups, but there's the looming effect of e-cigarette use that is counteracting some of those dietary benefits. So the other thing that has been identified which is a limitation, is that we didn't have any biological measures in some of these health surveys and limited diet information. So that's something that we have to consider in future population screening and surveys of our population. And what it is also pointing to is that we do need urgent actions to improve cardiovascular prevention in Australia, and I'm sure that this situation would be similar in other countries. So leading on from the profiles and people who are at risk of stroke means that when people do have their stroke, what is it that they're receiving? And is this given in an equivalent way? So one of the things that we know is that if we can improve stroke services, this will be essential for reducing the global burden of stroke. We will have more people surviving and fewer people living with disability. But the way in which we can do this is through better monitoring and reporting of the stroke burden, the access and quality of services, and providing relevant data for policy and planning. And in doing that, we need to establish good data systems to capture relevant and appropriate information for diverse populations. So my role in Australia is actually, I have oversight as the data custodian of the Australian Stroke Clinical Registry, and I'll be producing some findings from that for you, just to give you an example. So when we've undertaken an analysis of access to important treatments for ischemic stroke. So ischemic stroke, within the first few hours of that event, if you can offer reperfusion treatment, so a drug that can help dissolve the blood clot, or an intervention such as mechanical thrombectomy where the clot can be extracted, this can have a big impact on whether someone's going to survive their stroke or, in fact, have less disability. But you can see here that we lack a lot of information on where these services are available, and if, in fact, there is not equitable access around the world. So acute treatment of stroke, there's reperfusion therapy, which I've mentioned, and for intracerebral hemorrhage, there's newer data coming out, and there's been recent guidelines published about care bundle approach. And this means that what needs to happen for intracerebral hemorrhage, time is also very important, but stabilising that condition, ensuring they survive the initial insult by managing their blood pressure, reversing anticoagulant associated hemorrhage, and offering neurosurgical intervention. So that may mean bypassing a hospital to take a patient to a hospital that can offer those therapies, or ensuring rapid transfer. What we are seeing, though, in terms of variation in treatment by gender or sex differences, is that in their presentation and the response to treatment, it can be quite different, and outcomes for women compared with men. And what has also been reported by the American Heart Association is that men also have a 25% lower odds of misdiagnosis than women. So we need to understand better why these differences occur. What we have been able to identify as well within our Australian context, so this is information from the Australian Stroke Clinical Registry that we reported using data from 2021, was that women were less likely to receive stroke unit care, have hyperacute antithrombotics, be mobilised on the same day or the day after their arrival to hospital. Fewer of them had a timely swallow screen or assessment, and and fewer of them were receiving secondary prevention medication when they were leaving hospital. Now, stroke unit care is where beds are collocated in the one area of a hospital, and you have a specialist team of medical, nursing and allied health that look after that patient and provide the early rehabilitation and support. And we know that that is highly effective in firstly delivering more of the evidence-based clinical practice guideline measures that we recommend, but also in terms of outcome. Unfortunately, only 3 in 4 people within the Australian context get treated on a stroke unit, so we still have a little bit of work to do there. These are just some examples of trends just to really illustrate the big disparity that can happen, and this is over time. So and this is data from 2017 to 2021 during the COVID pandemic. They're highlighted in that yellow panel. That in terms of access to stroke treatment or secondary prevention medication, you can see that even though we feed back these data, we haven't really been making good impact. So we need to do some work to better understand what's happening there. How this translates to patient outcomes. So with the registry data, we sent out a survey between 90 and 180 days after admission. And what we have found is that women compared to men are more likely to report problems with self-care, usual activities, pain, discomfort, or anxiety and depression. And their unadjusted rates of mortality were also 29% greater in women than men. And there's also greater rates of mortality specifically due to cardiovascular diseases other than stroke. So what's coming? What's coming is ways in which we can better address the disparities in care. And this is some work that I'm involved with the Australian Stroke Alliance. The problem within Australia is that most of our population will live on the seaboard. A lot of our central part of our country is desert. And what we have is 8 million people living in rural remote settings. So it's very hard to get access to brain imaging facilities. And they also therefore experience worse rates of stroke, but also poorer outcomes. And access to stroke units is very low, and we also can't provide reperfusion therapies for many people living in remote areas. So the innovations that are coming is what is it that we need to do to treat stroke in the field? We need to accelerate detection of blood to enable pre-hospital thrombolysis, because that is the main thing that determines whether or not we can treat with thrombolysis, because there is a risk of bleeding if we give it to someone, and someone who's already got a bleed in the brain can't have this type of treatment. Blood tests need to be undertaken, and using small field MRI or ultrasound or EEG are potential ways forward. There's so far only one technique has been adopted globally, and it's the bedrock of the mobile stroke unit ambulance. So what we have been able to do is implement one of those in Melbourne, and in many other countries they've been able to implement mobile stroke unit ambulances, but often these are only in urban areas. So what a mobile stroke unit team in an ambulance will do is bring the hospital to the patient. They are able to scan the patient in the ambulance wherever they're located, and then a stroke nurse and or stroke doctor and a radiographer are on that truck with the paramedics. And with this information, with this earlier treatment, we're able to really reduce the time to treatment with a thrombolytic. In clinical trials around the world, in Germany and the US, they've been able to prove that in major cities with suspected stroke who are potentially eligible for reperfusion therapies, that pre-hospital treatment in a mobile stroke unit is recommended. So now this is a strong recommendation, and this is because of the improved 90-day outcomes with a number needed to treat of 10, which is a very powerful intervention. However, these are very expensive and they're very big trucks. So the way forward is, what can we do to advance this space? So ultralight brain imaging is now part of the work that's being undertaken with digital connectivity for standard, what we're calling standard smart ambulances and aircraft. So this is where paramedics would be trained up in stroke, and they will have equipment that can tell quickly whether or not someone's got a bleed on the brain. We can marry that up with access to a neurologist through telehealth system and bridge the gap, therefore, for rural and remote pre-hospital care. We're designing this for Australia and testing it, but it is also applicable and will be applicable to many other regions. So this is just an example of what might be possible with the EM Vision, where helmet, where they're able to undertake these dielectric maps and determine the different fluid and volumes within the brain, and use that to localise and detect abnormality within the brain and whether or not they're identifying ischemia or blood in the brain. This is an example of these helmets. So they're at a very early development stage, and they're going to be tested in Australia in these smart stroke ambulances and aircraft. The other is we're working with a company called MicroX, where they're really shrinking down the CT scanning equipment so that they can fit into an ambulance. I just want to touch on nursing roles. My clinical background is nursing, and over many years, the roles of nursing have been identified as core to good stroke care. And this is because they're the only team members available 24 hours a day. However, in the past, it's been quite ill-defined and vague, not really well valued or underutilised, and we do lack empirical evidence around the effects of nursing care on patient outcomes. However, that evidence is growing. And just as an example, that this is a stroke nurse consultant who works in Melbourne, and they are really the core to fast tracking of patients through the hospital system, so code strokes, ensuring patients are getting their thrombolysis as soon as they hit the emergency department door. That whole team is connected, but the core to the coordination happens often through these advanced practice nurses, and they are also responsible for training the rest of the team and also ensuring that there's good data, such as through the registry, to help with tracking performance so that they can identify within each individual hospital how to, or where they need to focus on quality improvement activities. So the stroke nurse present has been found to reduce neonatal times by about 7-fold. Other things that are new, there are a number of examples here around how the new ICH guidelines are coming into place, so intracerebral hemorrhage guidelines. We've also got information coming out now about immune regulation and how estrogen might reduce apoptosis and oxidative stress in the brain. However, we still don't have any gender-specific stroke treatments that exist. And the only reversal agent now for people who are on anticoagulants, so people who are taking anticoagulants because they have atrial fibrillation, sometimes they go on to have an intracerebral hemorrhage. It's not many, but there is now an agent that can allow that reversal so they can be appropriately treated if need be. So now I'm just going to highlight a few innovations that my research program is doing to address gaps in care. And I think one of the key things is that we're involving people with lived experience and end users in the process, so working with clinicians across all aspects of stroke care, from in the hospital, pre-hospital, but also out in the community. So what we're looking at is different community-based interventions that we can test. We're looking at programs that allow for patient-centred goals for recovery. We're also thinking about how we can use digital tools so that we can get them out to many more people, and also consider those in terms of group-based programs. So some of the work we've done is specifically design a movement-based mindfulness intervention, because we believe this can help reduce stress levels, blood pressure, and there is some evidence that it may also influence blood glucose and lipid lowering, and it does have an effect for reducing anxiety and depression. So we've undertaken a phase 2 prospective parallel 2-group double-blind study, and we'll be analysing that data soon. But the important thing is that rather than, women are probably more likely to want to participate in this type of program, and this could be a very good way to encourage women who may not be as comfortable doing cardiac rehab programs after their stroke. So this is part of what's also coming. With digital health, most people now own a mobile phone and access the internet. So we can use that if we design things appropriately to make sure we can personalise and tailor strategies. We can look at effectiveness in terms of risk factor reduction, chronic disease management, and also improving lifestyle behaviours. So one of the for primary prevention, there is the stroke riskometer. This is an app that is endorsed by the World Stroke Organisation. It's free to download. I've put a QR code there. But we are also testing on whether or not that is effective in behaviour change and having people who are using the app seek primary prevention measures or address their modifiable risk factors. So we're currently undertaking to recruit 850 participants across Australia and New Zealand for that. With the CAPS program, this is something my team are developing with the Australian eHealth Research Centre. We have designed an app. We have involved both clinicians but also patients in speaking to us about how this might work. It's coupled with monitoring blood pressure, but also other physical activity parameters through a wearable watch. And the clinician has their own portal so that they can contact people virtually, talk about their health goals and needs, and this is all for secondary prevention, so after someone's had a stroke and left hospital. And then through that, they're also given sent messages through SMS to encourage them on their goals for secondary prevention. So this is something that we have tested now with patients, and it's up to the point where we're hoping to test that in a randomised controlled trial. But what's important is that when parameters of risk factors go outside the norms of what we expect, then an alert comes back and the clinician can contact the patient and think about the next steps and communicate with the general practitioner. So this is some exciting work that we're embarking on to ensure scalability, but also tie the loop in with better secondary prevention management. So in summary, this has been a whistle-stop tour, I guess, of all the things that are happening. There's many more things happening that I haven't been able to touch on, but I hope that there are enough references in there that might pique your interest for you to look up. It is really important that we co-design solutions. We consider our context and the things that are impacting our ability to better serve our communities, both through primary prevention, but through the whole stroke care journey from pre-hospital right through to long-term care. At the moment, we do not have any gender-specific treatments, but we need to start thinking about these and thinking about how we tailor them for women and tailor them to meet the needs of men, because there are some nuanced differences there, and routine monitoring via national registries will be important, because this is how we can assess our progress in reducing treatment gaps. I just want to acknowledge people that have provided me with some slides for my talk today, and I just want to thank you for listening, and I hope you have a great panel discussion. Thank you.
Many thanks to Professor Cadilhac, although she is not able to listen to us. Well, there are some questions in the questions and answers. to Professor Nudy. And well, I would like to start with one, and then we will go through the Q&A. You
Sure.
said, if I understood well, that there is a difference in the behavior of coronary heart disease and stroke in what concerns the window
Yeah.
therapy with hormones. You presented data showing that there was a difference in the behavior of coronary heart disease and stroke in women between 50 and 60. So for one who is not well, doesn't understand well how is the vascular biology, one
Hmm.
may ask how is it, because it's supposed
Yeah.
that we are speaking of vasculature in one and the other area. So
Yeah.
I would like
Yeah.
you to comment.
Yeah, absolutely. So, I mean, it's an excellent question. So, when we look at coronary heart disease, when hormone therapy is initiated in younger women closer to the onset of menopause, there may actually be cardiovascular benefit, like reduced coronary heart disease events. And as I showed with that figure with the monkey study, significant reductions in atherosclerosis and plaque size when hormone therapy is initiated in younger non-human primates immediately following menopause onset. We don't really see that with stroke. There still appears to be an elevated risk with hormone therapy and stroke risk even in younger women. Now, the risk is small. It's rare, but it's still there. There are some hypotheses as to why that could be. And one potential hypothesis that I think is really interesting involves a patent foramen ovale or a PFO. So a PFO is a connection between the right atria and left atria in the heart. And hormone therapy may be prothrombotic, makes patients more likely to have a blood clot. So about 1 in 4 or 1 in 5 patients have a PFO. So if hormone therapy induced a small blood clot, and this blood clot was able to travel from the venous circulation over into the arterial circulation via a PFO, and then travel to the brain, it could potentially cause a stroke. So that's one interesting hypothesis that's out there regarding that question that you had.
Excellent. It's news that, well, it's an excellent explanation.
Yeah.
Okay, we have another question here from Dr. Duralde for Professor Nudy's meta-analysis of stroke risk with menopausal hormone therapy. Were all studies using oral estrogen?
Yeah. So the overwhelming majority of included randomized trials tested oral estrogen. There is one small trial called the Papworth HRT atherosclerosis trial. It was in about 255 women, and it tested the effects of transdermal estrogen on some harder cardiovascular disease endpoints. Most of them were ischemic heart disease endpoints. They actually didn't look at stroke per se as a secondary outcome, but that was included in that meta-analysis because they did report some systemic embolism endpoints. And that's another thing that's important to keep in mind. When I presented the forest plot of that meta-analysis, that was looking at a composite outcome. It included stroke, TIA, and also systemic embolism like DVT and PE. So that's certainly a limitation when looking at those forest plots that I presented.
Okay, many thanks. There is also here another questions. If there are studies which have done on the relationship between cardiovascular disease risk and use of testosterone pellets. So we are here in one main point because this is becoming very popular now.
Yeah.
The pellets of testosterone. So the question is if there is any.
Yeah. So what I will say is I am unaware of any large trials testing testosterone pellets and actually assessing hard cardiovascular disease endpoints. I'm unaware. It doesn't mean that they're not out there, but I'm unaware. Professor Cano, are you aware of any studies that have looked into that? I personally am not.
Not at all.
Okay.
Okay. So another questions. It goes back to the use of transdermal estrogens. You think there is any differential effect of transdermal estrogens versus oral estrogen? You already answered a part of
Yeah.
that, but would you like
What?
to comment a little bit more? Yeah.
Yeah, so essentially with transdermal estrogen, we're very limited with the quality of evidence that is available. There are very few, if any, randomized clinical trials looking at transdermal estrogen and stroke as either a primary or secondary outcome. I would say that none are out there. So we're really limited to observational data that has a lot of limitations. I mean, one of the main limitations of observational data is confounding variables that could be present with the associations. But I presented some of the larger observational data on the topic, and it doesn't appear that there's an increased risk with stroke with transdermal estrogen. But again, we're looking at observational data, which could have some confounders present. So.
Okay, many thanks. This is there is also a question here from Dr. Bronson.
Okay.
I think the point is progestins or progestogens, and well, he says that well, there are data about MPA, which has been considered from some points of view as a potentially dangerous drug. While progesterone or micronized progesterone, which is the form in which we used to have it in use, it seems that this problem does not exist. So that takes us to the point of if progestogens have something to add in terms of risk of stroke to estrogens, and in that case, as Dr. Bronson is asking, if there is any difference between progestogens and particularly MPA or micronized progesterone.
Yeah, I didn't really go into it in too much detail in my presentation. When I presented the figure on the timing hypothesis or critical window hypothesis, I know that the investigators at the Wake Forest University Primate Center looked at conjugated equine estrogen following surgical menopause. I also made it a point to present in the clinical trials in humans what was actually tested. And as you saw in hers in WHI, the medroxyprogesterone was tested, and we're kind of limited with different formulations of progesterone based off what's been studied before. But it's an excellent comment. It's an excellent point. Unfortunately, I just don't think that there's good randomized clinical trial data out there testing some of these different formulations.
Yeah, this is certainly important what you
Yeah.
mentioned, because from that point of view, in which probably a difference between estrogen and estrogen plus progestins might have to do with the prothrombotic action of progestogens that with the new progestogens has been something around. So in that case, it might be interesting to investigate, but as you said, there is very little, if any, data about that. Okay, there is another question here about young women. Young women have less absolute risk of stroke, but you know that we have, as we have just commented, the point of the contraceptives, the point of pregnancy also, in which it seems there is also an increased risk, particularly if women have preeclampsia, for example. And from that point of view, I wonder if you have some comments about this particular profile of patients, young women.
Oh, so could you just repeat the question?
Yes.
So what was it
yes.
about younger women?
Yeah, about younger women is if there is an increase in risk also, because these women used to use contraceptives, hormonal contraceptives, for example. Also, pregnancy,
Yeah.
particularly preeclampsia, as for example, which is more prevalent nowadays, in which women used to get pregnant at older ages, and they have increased risk of preeclampsia. So if there is something to mention about what is the scenario in this
Yeah,
type
I
of,
mean, it's a great question. As I presented on one of my earlier slides, preeclampsia and gestational hypertension are now recognized as risk enhancers for cardiovascular disease later in life, including both coronary heart disease and stroke. And it's now listed in the guidelines. So we certainly know that it increases the risk. Whether or not specifically using hormone therapy in that population reduces the risk, I don't quite know the answer to that question, and I'm not quite sure that there's high quality evidence to kind of guide us in that area, but it's certainly an interesting question.
yeah, more questions here. Yeah, the point of whether is there any tool to calculate absolute risk for a stroke, and if that might be used, for example, to filter women who wouldn't be appropriate for receiving hormonal therapy?
Yeah, I mean, it's a good question. I'm unaware of a direct tool to calculate absolute risk of stroke. I know that there are a lot of calculators out there. A lot of the calculators predict atherosclerotic cardiovascular disease, which is very much an umbrella term, including myocardial infarction and stroke. I know in the United States, we use the pooled cohort equation for patients who don't have a history of atherosclerotic cardiovascular disease, and it gives us the absolute risk of patients developing an event over the next 10 years. But like I said, it's more of an umbrella term for atherosclerotic cardiovascular disease. It's generally thought that patients at a very high risk, that being greater than 20%, of having a cardiovascular disease event over the next 10 years should probably avoid hormone therapy, but again, evidence is limited. And we actually have a new calculator that was just published in JAMA called the PREVENT calculator, which hasn't quite made its way into guidelines yet, but there is a new calculator out for atherosclerotic cardiovascular disease.
Okay. Trans women, do we have any particular message for this type of patients which used to receive high doses of hormones?
I'm unaware of any good evidence to guide us in this area. Professor Cano, are you aware of any or anything that you would recommend? I'm unaware of any high quality evidence to guide us in this area.
Mm-hmm. And another option, which is quite popular now in treatment, which is the hydroepiandrosterone, which is used, as you know, not only in women, but also in men, but in women it's used. And this takes us to the point of, again, androgens, whether androgens have any effect. So instead of testosterone, if in those cases in which, well, the prescribers, there are many prescribers of DHEA, and well, I don't know if we may send any message concerning potential risk, if there are any. Probably we don't have data. I don't know. You will say, but
yeah,
yes.
Again, it's another difficult area where this may be associated with a slightly increased risk of cardiovascular disease, but data is limited.
Okay. Well, I think there is only one last question here, which is the older women. It's not only the women who we used to visit, this 50, 60, but what about women who are 70 or older, that in some cases they also come to our offices for
Yeah,
being visited? It is supposed that probably they are at higher risk,
yeah.
but and we all know that this is not the type of patient for receiving menopausal hormone therapy. But is there something that we can do to reduce or to improve their potential risk of stroke?
Well, when older women come to clinic, well, actually, when any patient comes to clinic, there's always an opportunity to assess their risk of cardiovascular disease and potentially reduce their risk of cardiovascular disease. What I will say is any patient who has known atherosclerotic cardiovascular disease, a low dose aspirin has been shown to reduce the risk of stroke. That's not the case in a primary prevention setting where we are no longer routinely recommending aspirin. I also would say assessing a patient's lipid profile. And if patients have an elevated risk or high cholesterol, statin medications have been shown to reduce the risk of stroke. And then also assessing patients' blood pressure. And if they meet criteria for antihypertensive medications, intensive blood pressure control can also reduce the risk of stroke. So there are other things that could be done as well when we see these patients in clinic.
Lifestyle, for example?
Yeah,
Any
yeah,
recommendation?
exactly. Lifestyle recommendation, increasing physical activity. There's some data that the Mediterranean diet could reduce the risk of cardiovascular disease events as well. Smoking cessation too is very important for reducing stroke.
Okay. Professor Nudy, many
Yeah.
thanks. It has been a real privilege to have you here answering questions so different from so different points of view. So many thanks, and I hope you will enjoy the rest of your break that you are now taking these days. I should say that Professor Nudy has stopped his holidays. Okay, so just to finish this session, 3 more slides. One is just to bring you information about the many options that the IMS we are opening for members and also for people who are not members of the society. You have here, obviously, the next Congress, we will see another slide, but we have the journal, Climacteric. We have courses like Impact. We have the CAMS, the Council of Affiliated Menopause Societies, and also different options like webinars like this one, for example, which is an example of those educational activities from IMS. Also, the next slide, you see that, yes, as I said, there are exclusive offers for IMS members. For example, free 1 year IMS membership with completion of IMPART level 1. IMS membership offers in partnership with local and regional societies who are members of CAMS. And we are have introduced monthly live events and extensive library of educational resources. I want to end this webinar without bringing you this poster of this picture of our Congress, the 19th World Congress, this year in Melbourne, October from 19 to 22, in which it will be a real pleasure. We will be delighted in having many of you, as many as possible, in this Congress, in which we will update many areas regarding the attention to women's health at midlife. And many thanks. I hope you have enjoyed this webinar as much as I have, and have a good day, night, or afternoon, depending on where you are. Many thanks.